Okay. Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning. This is Dr. John Bennett broadcasting from sunny Miami Beach tonight. Today we have, or this morning from Miami Beach at nighttime China, we have the Chinese Neurosurgical Journal Webcast, the bi-monthly, and we're graced with the presence of Chandra Diopujari, and we're going to have Wan Li give the proper neurosurgical introduction to Chandra. Welcome, Wan Li.
Okay, thank you, John. Welcome, everyone. Good morning, good evening, and good afternoon. This is Yuanli Zhao from China. Today that will be that 62nd webinar of our Chinese Neurosurgical Journal. And now we have two speakers. The first speaker will be Dr. Chandrasekhar Dupajari from Hinduja Hospital, Mumbai, India. And he will talk about the surgery for craniopharyngioma, endonasal endoscopy, or transcranial microsurgery. So please, Dr. Chandrasekhar.
Thanks, Dr. Yunil. And it is really my pleasure to join this webinar. And thanks for this invitation. What I would do over the next half an hour or so is to talk about the changing paradigm in treatment of craniopharyngioma. And I'd share my screen with you. Can you see my screen?
Yes, it's not presentation mode yet. There you go. Perfect. Perfect.
Okay. So basically, I will discuss indications and some of the technical considerations why we do a particular kind of surgery for craniopharyngioma and how this concept is changing in the new millennium. So basically, there is a lot of interest, as you will find in several papers which have come in the last 2 years, which have discussed this point about craniopharyngioma resection by endoscopic endonasal versus transcranial approach. There are systemic reviews, there are meta-analysis. This one particularly, which is recently published in Frontiers, analyzes 8 studies comprising 376 cases. The strength of this study is that it actually talks about the last decade mainly, and therefore is more representative because many other studies have shown the traditional cases earlier and compared them to the recent endonasal cases. Here also you find that there is a gross total resection in terms of endonasal approach is higher, about 61% compared to 50% in the transcranial approach. The visual deterioration is much lower. Panhypopituitarism is lower. CSF leak is higher, but meningitis rates remain more or less the same. This is another one which is published in World Neurosurgery a couple of years ago. And this talks about 22 studies comparing approach. This also shows that endonasal approach has a better resection rate, better visual improvement rate, and lower recurrence rate. We have another paper which has recently come in Brain Sciences, which talks about a very large number of patients, and again, very contemporary series, 2012 to 2022, with a follow-up of minimum 3.5 years and comprising of more than 1,300 cases. And again, you find that there is a better visual outcome, 41% against 25%. Diabetes insipidus is less than half of what it is with transcranial approach. The recurrence rate is also slightly lower. The CSF leak rate, of course, is 9%, which was much higher before 2009, before the advent of analysis of proper closure techniques, especially the vascularized flap. So these are various parameters which they have checked. I would not go through them. But basically what we are looking at when we are looking at a patient of craniopharyngioma is to improve vision, to decrease the raised intracranial pressure. And of course, like any, this is supposed to be a benign tumor according to WHO classification. And therefore, our aim should be cure from the tumor. And the most important thing in this particular area is to preserve the good functional status. And this is where there is a huge difference of opinion. If you look at non-neurosurgical literature, this is in European Journal of Neuroendocrinology. And here they have shown that peak age at onset is 15 to 22 years. There almost 390 patients were analyzed, and poor state of health of patients treated for craniopharyngioma is marked reduced quality of life has been a major worry. However, they have also shown that transphenodal approach probably has a slightly lower endocrinal morbidity than the traditional transcranial approach. This is another paper which talks about the endocrine outcomes, and this is more recent. And this again shows that there is a similar proportion of endocrine outcomes and recurrence in both endoscopic and transcranial groups. So the most important reason why this happens is total versus subtotal excision, and what achieves a better or more radical excision. And the adherence of the craniopharyngioma becomes the most important talking point, that is it invaginating the hypothalamus or not. And these are pictures from William Sweet's article more than 25 years ago, where he had shown beautifully that these are invaginations. These are not actually infiltrations. The other problem is that most people feel that craniopharyngioma is different in children and adults. We now know that they are not only morphologically different, but they are molecular biology-wise also different. And in children, there is more evidence of raised intracranial pressure, hydrocephalus. Most of them are adamantinomas. There is a mutation of beta-catenin, and 15% patients with endocrinological deficit, while much more percentage in teenage and adults. And calcification is also seen in a much higher percentage. However, the GTR rate is probably slightly lower in these patients. So hypothalamic involvement has been taken as the most important criteria for resection of these tumors, and this has been very prominently brought into focus by the Paris group, where mainly they were talking about children, that there is no involvement of hypothalamus, then you are more likely to have a good result. Hypothalamus is severely indented, you may have a suboptimal result, but if the hypothalamus is involved or is not seen very well, then you are most likely going to have a major issue, and here you should not try for a radical excision. Attempts at radical excision are also determined by the fact that the tumor may be cystic, calcified, or mixed. And the presentation also becomes important, like raised intracranial pressure, associated hydrocephalus, prechiasmal or retrochiasmal location, and occasionally either motor deficits or psychological symptoms. There are several other classifications like central and peripheral, and there are several other ways which tell us that the importance of adhesion to the stalk is most important, and there are several classifications made by the Spanish group and the Chinese group depending on how much area is adherent and what kind of adherence it is, and determining the outcome in these patients. In very small children, there is also a problem about small nasal aperture, ill-defined turbinates, delayed development of sinuses, narrow intercarotid distance, size of the airspace in the nasal cavity is small in children, and disruption of skull base growth centers is also a worry for most of the people who are deciding on operating transphenodally or transcranially in very young children. However, you will find that there are now enough papers. This is a paper by Dr. Liu, where he has done meta-analysis where they have shown that endoscopic skull base surgery has shown to be safe and effective in children. And we have published our experience about 3 years ago in more than 60 children, where we have also had a similar good experience. There is another way to classify them is this is Sami's classification, where it talks about grade 1 being intracellular and grade 5 being reaching septum pellucidum or going paracellular. So most important thing is, where does it originate from? It can originate from anywhere from the Rathke's cleft cyst, and depending on that, I think our approach can probably be tailored properly. And this has come very nicely in this Korean paper, which shows that if you have the diaphragm covering the tumor and the origin of the tumor is mainly within the sella, your best bet is to do it by transsphenoidal approach. If it is going anteriorly, it may break the diaphragm and go under the optic chiasm. There, it may be easier for you to do it by transcranial approach, while if it goes back with is probably better. And these are the various approaches which can be done, especially in a very giant kind of tumors. And this 3D model, which shows that the axis of the tumor is the most important, and you will find that the infundibulotuberous craniopharyngiomas are probably the most prone for hypothalamic injury because they are growing upwards. But the tumor going in the retrochiasmal location, they are probably best suited for transsphenoidal approach. Kasam made this classification. The pre-infundibular is equally good for transcranial or transsphenoidal approach. The transtubercular is transinfundibular is equally difficult for both, but probably preferable is transsphenoidal approach. And for retrochiasmal, I think it is extremely important that we try a transsphenoidal approach because the morbidity of transcranial approach is higher. So this is how I would summarize how we should do it. Let's talk about the technique. I think let's see that if the tumor is mainly cystic or in cellular area or infradiaphragmatic, the transsphenoidal approach is of course the easiest. This is a young lady who's presented with this kind of tumor. The diaphragm is probably intact, and we went ahead and operated on this girl. And you can see that this is the dural opening. This is the frontal, the area over the planum. Planum has been drilled out. This is the cellular area. We are going to coagulate the anterior intercavernous sinus and then get into the tumor. And once you see that the tumor is being first emptied, and then the tumor wall is being dissected. Sharp dissection is probably very good in many of these cases, and you can excise almost all the tumor. As you can see over here, the diaphragm has remained intact. There is no opening into the arachnoid, and this tumor is the intracellular kind of a tumor where you have achieved a satisfactory excision in this patient. This is the postoperative scan 3 years later, and she has remained quite well, though she is on slight hormonal supplements. The other thing which has also improved is with navigation and better drills, we can now drill out even a completely non-existent sphenoid sinus. So this patient has virtually no aerated sphenoid sinus, and in spite of that, it has been possible to excise this tumor completely. As you can see, this child was well for about 8 years, then developed a small recurrence and had radiation afterwards. Intraventricular craniopharyngiomas are certainly tumors where we prefer that it should be done by either endoscopic or microscopic approach, but from transcranial approach, because the hypothalamus is at the bottom and we should not sacrifice it. And this is one such patient which we treated. You can see that the floor of the third ventricle is intact, which is an important criteria, and therefore we are going transforaminal. And here the tumor is being separated. The cyst wall is being separated from the floor of the ventricle. And you can see that there is a clear floor of the ventricle seen here. And we have been able to remove this tumor almost completely, except for a small bit of calcification. It is about 10 years. And this patient has had no recurrence and is growing quite well. This bit of calcium was also later on removed. And you can see the intact third ventricular floor here. Ventricular tumors can also be operated by endoscopic approach. There are several people who have shown isolated cases. This is one such patient we operated. This video is unfortunately not working, but you can see that the cyst was first collapsed and then gradually separated and completely removed after approach through the frontal horn. For suprasellar craniopharyngioma, as we talked, I think for pre-infundibular, both are equally good, but our preference is to go transsphenoidally. There are very few cases where you may decide to go transcranially. In this patient, the infundibulum was in front of this lesion, and therefore we were a little bit worried, and it was mainly cystic. Patient wanted a very minimally invasive procedure. So a small supraorbital craniotomy has been done, and it has been possible to open the cyst and then gradually take out the cyst wall, as you can see in this patient. When the tumor is retrochiasmal, you can do it through lamina terminalis, and this is one such example where we have managed to remove this tumor by translamina terminalis approach. The whole tumor could be removed here because there was very little space between the two optic nerves and the tumor was presenting backwards. And at the end of this, you can usually see the basilar artery and the perforators quite well. This is another patient where the tumor has grown in almost all directions, and therefore all the corridors have been used to remove this tumor. However, transsphenoidal approach works quite well. You see that the pituitary gland has been pushed back, the infundibulum has been pushed back, and most of the tumor is in direct line for your endonasal approach. And in such patient, you will open the planum, you will ligate or you will coagulate the anterior intercavernous sinus. And after this, the calcified component of the tumor being removed. At the back, the pituitary is kept intact, as you can see during this procedure. And then the pituitary is right here, the stalk is behind, and the whole cyst wall is being gradually. This is the liliaquist, which is at the back of this lesion. And then this is the Gerson surgery now. Even when you have the tumor going slightly to the lateral aspect, it is possible to get this tumor as long as there is enough space between the arteries here. And this patient was operated. You can see that, sorry. This patient is operated by transnasal approach. Again, we are opening the planum here. And then the tumor is being, cyst wall is being excised. We are trying our best to keep the, this is the tubercle, this is the stalk which we are trying to keep intact. And we have managed to keep the stalk intact. Then we put our attention to the lateral part of the lesion. And you can now see that even that part of the cyst has come out, and you can actually look inside the Sylvian fissure, and you can virtually see the middle cerebral artery here, and the stalk has remained intact, and the cyst has come out from here as well. The postoperative picture of this patient. This is a recurrent cystic craniopharyngioma, again naturally occurring corridor from here, and therefore we went transsphenoidally, good sphenoid sinus, again a planum opening, and the anterior intercavernous sinus is being ligated. And after that, you start removing this tumor. You can see that the tumor is coming out nicely, but it is quite adherent to the stalk. The stalk is being separated by blunt and sharp dissection. This is the stalk at the end of it. And you can see the foramen of Monroe on both sides. You can see the basilar artery in the interpeduncular fossa, and the whole stalk is intact in this patient, and there was no hormonal disturbance after the surgery. This is a postoperative scan. For infundibular tumor, it becomes a little difficult as you will see that the cyst has been drained, but the tumor is very difficult to remove unless you damage the stalk, and you have to take a decision if you are going to damage the stalk or you will do a subtotal excision. Here we decided to keep a small piece of calcium on the stalk, and we have managed to keep the stalk intact in this young girl who's grown up well afterwards. In a completely retroinfundibular, you have to definitely drill the posterior clinoid or the dorsum sellae, and then you get into you first making the flap, and then you are drilling the dorsum sellae, you're cutting the ligaments around the pituitary, and once you have done that, you go behind this, the pituitary gland is being pushed forwards, and then the cyst is being brought down from the interpeduncular fossa. You cannot push too much traction. You are doing a counter traction as well as some dissection with your suction in such a situation. And then eventually we are taking the cyst wall out from the under surface. And you get into the ventricle here. This is the post-operative scan. This lady, again, for 5.5 years, she had no recurrence, but then she had a small nodule, and which was treated with radiation. This is another patient where you can see that the cyst wall has been completely on one side. They were very much worried about the fact that we may have a problem with that. She was against going transnasal, and we thought the hormonal preservation will be better because again the stalk is in front. So in retroinfundibular kind of cases, probably there is still some space for this kind of a surgery. And here you can see that there is no tumor seen between the optic nerves. The tumor is presenting between the carotid and the optic nerve, and here we are managing to remove it bit by bit. After removing the cystic component, the solid component is being and the whole thing could be removed without causing damage to the stalk. And this lady is also done quite well with very little hormonal supplements. But when you have a giant tumor like this, I think the best bet is to do a proper craniotomy like we have done in this patient. And then you can still use your endoscope through various corridors to make sure that you have been able to remove this tumor completely. Like you will see that you can see on either side of the carotids, you can still preserve the stalk and make sure that you have been able to get the whole tumor from all the corridors which are available to you. In this case, this is the third nerve, as you can see. So various corridors are available even from transcranial endoscopy. And we still keep our options open to do either of the approaches in such patients. I think when you have largely calcified tumor, then I think I still prefer to do a transsphenoidal approach, like transcranial approach, like we did in this patient with supraorbital craniotomy. We managed to remove the whole tumor, which was virtually ossified here. And when there has been previous vascular injury, this patient was previously operated for a recurrence. She came, and you can see that one ICA is already damaged. So in this patient, the cystic component we excised and then subjected this patient to radiotherapy. If you have a hydrocephalus associated, then we have devised this combined endoscopic approach where we first take away the cyst from a transventricular approach, like in this patient. And after that, after taking the draining the cyst, we will put a reservoir, or we put a reservoir inside, so that in very young patients we use intracystic therapy as well. And then these patients after a week or so are taken for transsphenoidal surgery like you find in this patient. And the advantage of that is that after we have removed the calcification, and the cyst has already been drained, and the cyst wall comes out very easily. So the tumor separates very easily from the hypothalamus, and you can get into the third ventricle quite well. And this patient has done quite well. It's about 3 years following the surgery right now. In a tumor like this, it becomes extremely difficult. So we first did a craniotomy in this patient. The patient was hormonally intact. We achieved a subtotal excision, and you can see that the tumor is being gradually removed from the various crevices, and eventually we have been able to get most of the tumor out except for some cellular component. When this tumor started growing again, it was mainly in the sella, and therefore the second surgery after about a couple of years was done by transsphenoidal approach. And here we have been able to get the whole tumor out quite well in the usual manner. And you can see that the diaphragm. So in spite of the fact that this tumor has grown on both sides of the diaphragm, it was possible to remove the tumor completely. The child is on a small dose of steroids. So we have used sterional craniotomy intrahemispheric approach in our earlier cases, but even continue to use it today. All the intraventricular tumors are operated by transcranial approach, earlier microscopic, nowadays endoscopic. And we've done the last 25 cases by endonasal transsphenoidal approach, and combined approach has been used in about 25 patients. So I think for a cellular infradiaphragmatic craniopharyngioma, transsphenoidal endoscopic approach is probably the best. It is probably also very good for supracellular retrochiasmal tumors, especially about 3 years of age. I think when you have a supracellular prechiasmal tumor, either approach can be done quite well. For a retroinfundibular tumor, occasionally, especially if the tumor is small and tumor is calcified, it may be better to do transsphenoidal. And we would avoid a transsphenoidal approach in intraventricular tumors, multicompartmental tumors with lateral extension when there is heavy calcification or vascular involvement. And combined or staged procedures are probably important in consideration in craniopharyngioma patients, as we have to treat them for a fairly long time. I think this is not a disease which is getting cured in one surgery, and you may have to look patient over a prolonged period of time. I think endocrinological literature emphasizes that probably transsphenoidal approach gives a better result, or a stage approach gives better result, and that would be the message which I would like to give in this. So we better individualize the management of craniopharyngioma, and you should be prepared to do all kinds of approaches, including intraventricular endoscopy, transsphenoidal endoscopy, as well as transcranial microsurgery. Thank you very much. We'll be happy to answer any queries, questions.
Okay, Juan Lee?
Yeah, I'm here. Yeah, thank you, Chandrasekhar, for your nice talk. I saw some. Are there some questions from?
Sorry?
No. I just asked if there's any question from the audience.
Harshad, how you doing?
I'm fine, John. How I'm fine.
Welcome.
Thank you very much, Dr. Shekhar. Wonderful lecture, as always. And you have been pioneered in craniopharyngiomas. I've heard you many, many times. Just a small question which I thought I'll ask you. Does the presence of a calcification in the sella decides the approach, or you still go transsphenoidal? And second, when a tumor is retrochiasmal, is there any different technique you use to separate the vessels around the optic chiasma from the tumor? Because it's very important to save these perforators and the vessels, otherwise we lose the vision and deterioration of vision, which can happen.
Thank you, Harshit. As far as the first question is concerned, if the calcification is predominantly in the sella, it is still possible to do a transsphenoidal approach. I think what is more important is what type of calcification. Sometimes you get amorphous calcification, which you can easily separate with a dissector and take it out. Sometimes you get bony hard kind of calcification, large chunks, which become difficult to remove by either approach. The second question about the retrochiasmal tumor. So today my preference in a retrochiasmal tumor is to go transsphenoidal, especially if the infundibulum is behind the tumor. because it is much easier to, in terms of access, to go for a retrochiasmal tumor. If the patient is hormonally intact and if the infundibulum can be traced in front of the tumor, which is usually splayed in front of the tumor, and I have had at least a couple of cases where I decompressed the cyst and backed out, and did not go for a complete excision because patient did not have DI. So I think hormonal status is important. And second thing, what is important is if you can identify the infundibulum in such patients. Otherwise, lamina terminalis or the optic carotid corridor transcranially can give you a good excision of these tumors.
Thank you. Thank you
So
very much.
identifying hypothalamus and separating is easier from endoscopic transsphenoidal rather than from transcranial approach.
Do you have encountered any hypothalamic injury and they remain, obese for a very, very long time, or a permanent obesity in these cases?
I showed you one picture in the beginning. From the transsphenoidal series, only one patient has developed morbid obesity out of the 45 patients, out of which 29 are children, where we had obesity. In most other patients, about 1/3 of the patients, we had some kind of a disturbance, but 2/3 of the patients had no hypothalamic damage at all. On the transcranial surgery, I think this is a little more pronounced than transsphenoidal surgery.
Is there any role of upfront radiotherapy after the surgery in cases of residual tumor, or you wait?
If you have deliberately left behind tumor which you think you are not going to be able to remove, and in an adult patient where hormonal status is probably not so important, if they have finished their reproductive function, then maybe you can send them directly for radiotherapy. In young children, I do not usually send them for upfront radiotherapy.
Thank you. Very nice talk. Very informative, very educative. Thank you. Thank you.
Dr. Yuan Lee?
Yeah, I'm here. Yeah. Actually, I also want to know what about your opinion for the CSF leak? Can you give us a little bit
CSF
more?
leak.
Yeah.
So CSF leak has been a major issue, and till about 2010, we were seriously worried till we started developing our technique of nasoseptal flap and various other mucosal flaps. And after that, our CSF leak, out of these 45 cases, I think we have had only 3 patients who had to go back for readjustment of their flaps. And we have had only 1 patient who developed serious infection because of CSF leak.
Okay, thank you. Yeah. Okay, yeah. So there any
Yeah, I don't see any questions in the panel, Wanli.
okay.
I think
so
the time change has probably made
Yeah,
it difficult for
well,
quite a
you
few
know-
people.
Chandra, that's my job, and I should have known that. I should have known that. Should have checked. I'm sorry. I hope I didn't inconvenience too many people. Okay, Chandra, do you want? Excuse me, Wanli, do you want to move on to the next speaker?
Yeah,
Okay.
actually,
Thank you,
I'm
Chandra.
checking if the second speaker are already online. Just give me 1 minute.
Okay, well,
Yeah, just 1 minute.
oh, I think he's on. He's here. Hello.
Hello? Hello?
Yeah.
Can you hear
Yeah.
me?
Hi. You're here. Okay.
Yeah.
Wanli, he's here. Okay. So you
Yeah,
wanna-
okay, yeah,
Okay,
Yes,
you
I saw.
want to introduce him, please?
Sure, yeah, okay. So yeah, now we have the second speaker of today's webinar, and His name is Dr. Zhi Yongshi, and today he's come from actually affiliate hospital of Nanjing University Medical School, Nanjing Drum Tower Hospital. Today he will talk about the research of clinical and hemodynamic based on 4D flow technique of extracranial intracranial bypass for complicate middle cerebral aneurysm. Dr. Shi, please.
Thank you. Good evening, dear editors. I'm Shi Zhiyong, attendant from the Department of Neurosurgery, Nanjing Drum Tower Hospital, Jiangsu Province. Today, I'm so happy to present my report. The title of my report is Research of Cerebral Hemodynamics of ECIC Bypass for
Excuse me, doctor,
complex aneurysm.
excuse me, doc, you're not sharing your presentation.
Okay.
You want to share it, please?
Okay.
Not yet. It's not full screen yet. It's there, but put it on presentation mode.
Okay.
Yeah, perfect.
Oh, okay. The definition is intra-aneurysm thrombosis, infected aneurysm, atherosclerotic thickening or calcification of arteries in the neck of the aneurysm, or diameter larger than 2.5 centimeter, or involvement of important perforators. The annual rupture risk of complex intracranial aneurysm is related to their location, with a rupture risk of about 5% per year, and there is no optimal treatment. Thus far, the treatment included conservative options, endovascular interventions, on the cerebral revascularization. Okay, conservative treatment has high risk of mortality. The endovascular therapy has complete occlusion of 50%, aneurysm residual of about 30%. However, ECIC bypass with aneurysm trapping can achieve complete occlusion of nearly 110%, but with operation-related infection of about 50.4%. What about ECIC bypass without aneurysm trapping? I'll explore this topic. Let's see warning case 1. This patient experienced 4 times endovascular treatment. He still had recurred. The recurrence which is unacceptable. Warning case to this 34-year-old woman diagnosed with bifurcation aneurysm of ICA experienced cerebral infarction attack after endovascular treatment. The CTA reviewed occlusion of MCA trunk at 1 year after embolization, and the STA-MCA bypass surgery was performed. Let's see the first surgical treatment, ECIC bypass with aneurysm trapping. For cases with parent artery cannot be preserved, the blood supply need to be reconstructed. Bypass options included superficial temporal artery to middle cerebral artery bypass, and superficial temporal artery radial artery to middle cerebral artery bypass. Aneurysm treatment options included bypass with aneurysm trapping, bypass with simultaneous partial aneurysm trapping, bypass with second stage aneurysm trapping, or bypass without aneurysm trapping. Let's see this case. This 50-year-old male patient was diagnosed with spinal aneurysm in M1 segment of right MCA. He was performed by double branches of STA was anastomosis to MCA tracts with aneurysm occlusion. He was discharged without any operation-related infection. The bypass graft was patent and the aneurysm was visualized in reversed flow. The patient did not complain of any discomfort after the bypass. However, pitfalls also occur. This case is 31-year-old woman with circular aneurysm of RCA segment. He was performed by ECA-RA-M2 bypass successfully. He was exposed to massive cerebral infection at the 6th day after bypass due to robust neck rotation. This case, this 52-year-old man with aneurysm of RCA cavernous segment, and he was performed by ECA-M2. He also experienced a new cerebral infection, although with the patency of bypass graft. What about ECRC bypass without aneurysm trapping? After bypass without aneurysm trapping, the reversed flow from the extracranial circulation and the integrated flow from intracranial circulation formed. When the reversed flow from the extracranial circulation suppressed integrate flow, the aneurysm will experience the disappearance. Otherwise, the integrate from the intracranial circulation suppressed the reversed flow from the extracranial circulation. The aneurysm will enlarge in the future, and this circulation second-stage treatment is necessary. According to previous literature, from 1987 to 1987, Professor Fox of Hopkins reported the use of a detachable balloon in combination with ECRC bypass for intracranial giant aneurysm, and the ischemic intolerance was observed in 9 of 65 patients. ECRC bypass was performed first in 4 of these patients with intolerance of BOT. After bypass, 2 cases tolerated BOT, 1 remained intolerant of BOT at 1 day, 1 week, and 1 month after bypass, but tolerated BOT at the 8th month, and the other aneurysm disappeared spontaneously after bypass. He proposed that per BOT first, if not tolerated, ECRC bypass was required. At last, permanent occluded parent artery was necessary. In 1987, Professor Surbininko changed the surgical approach by using permanent balloon occlusion of the parent artery after ECRC bypass, 1-stage occlusion to treat 9 patients. These 9 patients was treated without significant post-operative complications. However, in 1991, Professor Bimonthly from the former Soviet Union reported a case of aneurysm disappearance after ECRC bypass alone without aneurysm trapping. The patient present with hemiparesis of the right limb at the BOT and only ECRC bypass was performed. The follow-up showed that the aneurysm disappeared spontaneously. He hypothesized that it's extremely important to ensure the patency of bypass graft before permanent occlusion of parent artery. There is no urgency to occlude parent artery after bypass, and there may be surprises in the wait and see period. A BOT test is recommended before permanent occluded parent artery to ensure a tolerance of ischemia. Before permanent occlusion, is recommended to perform a BOT again to ensure that ischemic is tolerated. The use of the balloon is relatively precise and controllable for occlusion of parent artery. ECRC bypass without aneurysm trapping contributed to the aneurysm spontaneous disappearance, which was only limited to case reports. Thus far, there are 5 cases reported. We have some puzzles after ECRC pass with aneurysm trapping, how to overcome the incidence of post-operative cerebral infection of about 10%. For patients with old age and poor intracranial bypass vessels, what about poor quality of bypass graft? What can be done for complex aneurysms not passing BOT or involved important perforators? Is the permanent occlusion of parent artery necessary? What are the hemodynamic changes after ECRC bypass alone? Is there a remedy if the aneurysm does not disappear after bypass alone? After thrombosis of aneurysm achieved, does the risk of a natural rupture disappear completely? We proposed a staged therapy. Stage 1, ECRC bypass without aneurysm trapping was complete, causing competing flow in the integrate, and reverse direction. If the aneurysm disappeared, clinical follow-up was continued. If the aneurysm does not disappear, stage 2 treatment is performed to control the integrate flow. This is the flow chart. In this research, we utilized the 40-flow CFD analysis based on CTA and ultrasonography to monitor our hemodynamics. This is the flow chart. On the second, fourth, sixth, eighth, and 10th day after bypass alone, 40-flow examination was performed. Let's see this case. This aneurysm in the right MCA bifurcation, here was performed by STA-MCA bypass along with daughter sac clipping. The body of the other part of the aneurysm was not treated. After bypass alone, CTA reviewed the patency of the bypass graft, the occlusion of the parent artery, and the aneurysm shrinkage. At 3-week CT after bypass, CTA demonstrated spontaneous of the aneurysm, occlusion of parent artery, and the patency of bypass graft. The 40-flow analysis of STA reversed that. The flow and the velocity first increased and then decreased, which contributed to aneurysm disappeared. Compared to preoperative hemodynamics, the ratio and the velocity of after surgery significantly reduced. This 62-year-old man with a right M1 aneurysm was performed STA-RA-M2 bypass, and the aneurysm disappeared after bypass. We can see the CTA dynamically. At the 10 months after bypass, the aneurysm disappeared. The bypass was patent. This 27-year-old woman was diagnosed with a right MCA spinal aneurysm due to headache discomfort. She was treated by STA-M4 bypass. The aneurysm gradually disappeared after bypass. We can see the dynamic evolution of aneurysm based on CTA findings. At the 6 months after bypass alone, the aneurysm disappeared spontaneously. This case was different. A 23-year-old woman, she was diagnosed with right M1 aneurysm. Right STA-M3 bypass was performed, but the aneurysm enlarged after bypass. He was performed by endovascular embolization, but with a residual left. After 1 year after embolization, the residual disappeared. The bypass was patent. This 40-year-old man with circular aneurysm of left MCA, and she was treated by STA-RA-M2 bypass. However, the bypass artery gradually shrank and it became in a suppressed stage. At 10 months after bypass, the perfusion of the ECA was not obvious before neck compression. However, after neck compression, the ECA can perfuse intracranially. This case was diagnosed with left ICA giant aneurysm, and CTA examination 1 week after surgery. The bypass was patent. The aneurysm was slightly smaller but still developable. The 4D flow analysis revealed that the flow from the bypass graft first increased and then decreased on the 7th day after bypass without disappearance of the aneurysm. So he was treated by ICA ligation, re-examination of CTA 1 week after ICA ligation reviewed parent bypass graft and aneurysm disappearance. He was discharged without any complication. We concluded that ECIC bypass alone complicates cerebral hemodynamics of aneurysm, which may cause uncertain future of the aneurysm. ECIC bypass with second-stage aneurysm trapping can be used to treat partial complex intracranial aneurysm, causing complicated hemodynamics changes. Compared to preoperative hemodynamics of bypass graft, post-operative 4D flow analysis reviewed a turning point characterized by first increase and then decrease trends, which might occur 1 week after bypass. The post-operative hemodynamics in parent artery was different, which might be associated with aneurysm secondary change. For patients with aneurysm disappeared, a decreased tendency of parent artery after TP was observed. Conversely, for patients with aneurysm enlarged or unchanged, an increased tendency of flow and velocity after TP was observed. In some patients after bypass, the wall share of the aneurysm is reduced, slowing down blood flow and favoring thrombosis. Besides, preoperative CFD can verify the presence of rupture-prone areas. These red arrows, which can be addressed during surgery. Moreover, ECIC bypass alone can result in partial occlusion of the aneurysm. Otherwise, second-stage treatment was necessary. The supply and demand of blood flow of bypass graft is a dynamic process, and there is a competing offset between reverse flow from external circulation and antegrade flow from intracranial circulation competition, which determines the changes of the aneurysm. Second-stage treatments mainly focused on controlling antegrade flow from intracranial circulation. ICA ligation or interventional therapy was used to promote aneurysm shrinkage and occlusion. The absence of aneurysm rupture during follow-up does not mean the natural history of aneurysm rupture has been changed, probably because the follow-up time is insufficient. In the future, hemodynamic changes in velocity and flow of bypass graft after second-stage treatment needed to further studied. Is the second-stage treatment preferred endovascular coiling, permanent occlusion, or flow diversion stent? Is it complete embolization or partial embolization? How do you control the residual remaining after interventional embolization? Can a relatively standard surgical process be established for complex aneurysms? One stage of bypass with a specific time window for second-stage treatment. This is my personal viewpoint. ECIC bypass with simultaneously aneurysm trapping was the first-line treatment. However, easy IC bypass with second-stage aneurysm trapping was suitable for partial aneurysm, which was the second-line treatment. And last, I'll introduce our cerebrovascular surgical team. The surgical team of cerebrovascular department of Nanjing Drum Tower Hospital has 3 doctoral supervisors. Currently, it routinely carries out ECIC bypass, CEA, intracranial vascular system reconstruction, and vascular intervention, keyhole technique, and hybrid operation, covering the surgical treatment of a variety of cerebral and spinal vascular disease, which has an annual operation volume of over 1,200 cases. This is our team, our cerebral vascular surgical team. Thank you for my supervisor, doctoral supervisor, Zhang Dong professor, for the help and guidance of our research. Thank you. That's all.
Thank you, Dr. Shi, for your nice talk. You gave a very comprehensive introduction about the ECIC bypass surgery for the middle cerebral artery aneurysm. So, are there any questions from the audience?
Yes.
Please.
Hello, Professor. Wonderful lecture. Do you advocate ECIC bypass in all aneurysms? Number 1. Second, what is the mechanism of the aneurysm disappearing? And third, in some cases, the ECIC bypass did not disappear the aneurysm. So what is the mechanism behind these 2 things? Thank you.
Oh, thank you for your question. In our clinical practice, for cases with complex aneurysms, ECIC bypass with simultaneous aneurysm trapping was the mainstream. For partial cases with involvement of important perforators or unsuitable for aneurysm trapping, we first performed ECIC bypass alone. After a time window of follow-up, we conducted the second-stage aneurysm trapping. The main treatment, the main options of second-stage treatment is an endovascular intervention. Okay. That's all.
How long does it take to disappear the aneurysm after doing ECIC bypass? Till what period of time you wait?
Oh, excuse me.
Can you repeat that, Haoshan?
How long does it take after doing ECIC bypass for an aneurysm to disappear completely? How long you wait?
Hours. About 4 hours. 4 hours.
You do check angiogram immediately after doing ECIC bypass and see for aneurysm?
Yes.
Wonderful technique. Wonderful. Something to learn more about it. It's very good.
Thank you. I appreciate. Thank you.
Yeah, I'd like to make a remark. I'm not a neurosurgeon, and I don't have a full understanding of your topic, but I can tell you that we would like to continue communicating with what you're doing in the cerebral vascular area from you to our Western world. So I would like to have you do more webcasts, if you don't mind, with Neurosurgical TV. And I think and for you too to follow what's going on in our world in cerebral vascular surgery with this technology. This technology allows us to share with you, which is fantastic. The best time in history, in my opinion, to be a doctor. Best time. So I encourage you to use this, and we'll be asking you. Okay, any more questions before we close up, Juan Lee? Any more comments?
No, I think yeah, that's all. I agree with you that yeah, cerebral vascular surgery. Now we have many new techniques and change very quickly, like the hybrid surgery. Also, maybe next time we will find someone to
Yeah.
introduce the hybrid technique.
Yeah,
So some other.
and that's your field, right? Right, Juan
Yeah.
Lee?
Yeah.
Maybe,
I think I don't have any more comment.
maybe you can give a presentation.
Sure. Yes, yeah, I can do it.
We'll talk about that later. But okay,
Yes, of course, yeah.
thank you everyone for coming. Thank you, Harshad, for your comments and questions. And
Thank you.
thanks for the excellent presentation. And we'll be in touch.
Sure. Bye.